something. Like, today we are going to start with regenerative periodontal surgical procedures. Okay. So regenerative periodontal, already surgical procedures are going on. All of you know surgical procedures. We are enter in the treatment part. So in treatment part, so regenerative surgical procedures. In that, when regenerative procedures are done, any one of you? Any one of you can tell me when regenerative surgical procedures we do? What is line of treatment for any periodontal surgical periodontitis patients? See, at least if you answer something, I can tell the mistakes if they are there. Otherwise, I will learn something from you people. At least tell me something.
Scaling, root planing, curettage, flap surgeries.
So all treatment you will perform in a single case.
No, ma'am.
So see, whenever a periodontitis case is there, first you divide it in phases: phase 1, phase 2, phase 3. Okay. So in phase 1, basic treatment is scaling, root planing, and re-evaluation after 1 month. If the pocket subsides, bleeding on probing, everything gets clear picture, and still radiographically you will find bony type of defect or bony defect, intra-bony defect, not horizontal type of defect. So if intra-bony defects are present, then you can go for regenerative surgical procedure. What is mean by regenerative surgical procedure? You are going to build whatever lost component that you want to generate. So for that purpose, we call it as a regenerative surgical procedures. So regenerative surgical procedures, we want to, whatever lost component are there, like bone, there may be loss of periodontal ligament. The defect formation means what? There are changes takes place along the root surface, along the in the bone, and it forms in a 3-wall or 2-wall defect, or it may be a loss of periodontal tooth structure, loss of cementum, or destruction of cementum. So all these you need to recover. Once you do scaling, root planing, the area which is there, it gets healed by repair. So you want to regenerate all components. So for regeneration of bone, regeneration of periodontal ligament, means new attachment. We want which type of healing takes place in that area is new attachment. Means newly formed periodontal ligament should get embedded into newly formed cementum and bone. So that is actually complete new attachment procedure or new attachment which we want to outcome of our treatment. So whenever you do surgical procedure, whenever you treat, that it is not possible that at every time formation of new attachment takes place. So sometimes bone loss is more. In that case, you need to regenerate that component, lost component. So types of regenerative procedures are of basically of two types. Either if you are using graft, means bone graft, or any other material, or non-graft associated. So today we are going to discuss about non-bone graft associated technique, or third part is combination type of technique. Graft associated technique means what? Where you are going to use bone graft during your surgical procedure, that is regenerative surgical procedure. Sometimes if you are not using bone graft and you are using some other procedures like guided tissue regeneration, laser assisted procedure, or root surface biomodification, or some growth factors, if you are using, then they are called as non-graft associated. And thirdly or lastly, you can combine bone graft along with any of these procedures, that is guided tissue regeneration or any combination root surface biomodification. That combined type of technique is another method. So what exactly happens when you treat a periodontal pocket? Whenever you treat a periodontal pocket with bony defect, what happens based on Melcher's concept, or see if whenever you treat any bony defect is there, and whenever you are going to treat, that time what happens, all four periodontal components are there. That four periodontal components which are there, first is gingival epithelium and connective tissue, second is your periodontal ligament which is a connective tissue again, alveolar bone which is again a connective tissue, and cementum. So all these four components should be preserved properly. But what happens whenever you remove plaque, calculus, and the defect area where clot formation takes place? That time, speed of healing, which is there, it is more in epithelial cells. So epithelial cell turnover rate is very faster than that of other bone, other connective tissues. So what happens? These epithelial cells, if they run fast or they form fast, then it moves or migrate in the area of defect, and it occupies the area of healing area of connective tissues. हाँ मी घेते ना चॅट चॅट येते ना. So the area of healing is occupied by, the defect area is occupied by these defect area is occupied or populated by gingival epithelial cells, and these gingival epithelial cells, they populate that area, and they don't give space for connective tissue cells of periodontal ligament cells, other than that bone cells. So they don't get time as well as space, because the area is populated by epithelium, and long junctional epithelium takes place. This long junctional epithelium is not a desirable outcome. Which outcome we want? We want new attachment. New attachment means what? Newly formed periodontal ligament cells or ligament fibers should get embedded one side into newly formed bone, whatever lost bone. In that area, bone formation should be there, and then it should get embedded into cementum. So this type of attachment exactly we want. We want this should happen. But what happens? Epithelial cells, they grow more faster, and they occupy and populate the area of wound. So because of that, long junctional epithelium takes place, and this long, because of long junctional epithelium, which is a weaker type of attachment. Okay, so removal of to avoid that junctional epithelial cells to to protrude or to go into the defect area, which measures we can do is, first is removal of junctional epithelium and pocket epithelium. Its presence interferes, this junctional epithelial presence interferes with the direct opposition of connective tissue and cementum, thus limiting the height to which periodontal fibers can insert into the cementum. So to the methods to remove this junctional or pocket epithelium is curettage, then chemical agents, we can use sodium sulfide, phenol, camphor. Other than that, surgical techniques which are recommended are NAP, gingivectomy, modified, all these surgical procedures are there. But see, this epithelial migration, to prevent that, first is total removal of interdental papilla covering the defect and replacement with free autogenous graft. Means two surgical procedures you need to do to prevent the epithelial cells of flap. Flap is there to prevent that epithelial cells to downgrowth inside the defect. You need to preserve the area. How? Complete removal of interdental papilla and free autogenous graft is obtained from palate, and it should be sutured in that area. So it becomes difficult. So because of two surgical sites. And second approach which is used is coronally displaced flap. Means the flap which is present during surgical procedure, it should be pulled coronally, so that epithelial cell downgrowth which that distance is increased between epithelial and healing area. So epithelial cell will not run faster. Means even though if they run faster, the area of wound will not be occupied by them. So the basic aim of our regenerative procedure is mainly we want to stabilize the clot, blood clot after removal of the granulation tissue defect, whatever bone defect is there, that area we want to clean it. Then new whatever bleeding occurs, we want to stabilize that clot. Wound protection, wound should get protected, and space should be created for new bone forming cells or new periodontal ligament forming cells. So that space should be created. For that purpose, Melcher has given this concept, and based on Melcher's concept, Melcher has given the concept that periodontal ligament cells have pluripotential cells, or they have the capacity to form or get differentiated into all different types of cells. So periodontal ligament cells may get differentiated into bone forming cells, may get differentiated into osteoblast, cementoblast. So because of that, it helps in formation of all new structures. So space should be given to these cells, as well as wound protection, clot stabilization. All these are the important aspects for this treatment. So this Urban in 1982 has started various experiments, Urban and Neiman, and they use millipore filter paper. So EPT, or expanded polytetrafluoroethylene membrane. So these membranes have small pores, small filters are there, which helps in the maintaining the proper area. These these guided tissue regenerating membranes are there. So these guided tissue regenerative membranes, they protect the wound area, clot stabilization, and they prevent the epithelium to downgrowth or migrate in the wound area. So the space can be created by these membranes. Another method is root biomodification. It can be achieved by using citric acid, fibronectin, tetracycline. We are going in detail again. Another is enamel matrix protein, non-bone graft associated techniques. What happened, Mayur? Any problem?
No, ma'am. No, ma'am.
Okay. So non-bone, today we are going to discuss. See, today we are going to discuss about bone regenerative technique. In bone regenerative technique, which type of healing we want is new attachment type of technique we want. But healing, most of the times what happens, long junctional epithelium formation takes place because of epithelial cells. They migrate more faster along the root surface, and they occupies the space of wound. So that wound protection we want to do. For that purpose, we can use guided tissue regeneration. Regenerative procedures are of two different types. First is what? Non-graft associated, means non-bone graft associated technique. Second is bone graft associated technique. In non-graft associated technique, we are discussing about various types or various procedures. So first procedure is guided tissue regeneration. Second procedure is various growth factors, enamel matrix proteins, then polypeptide growth factors can be used. Other than that, root biomodification can be done. So first we will discuss about guided tissue regeneration. Okay, so method of prevention of epithelial migration along the cemental wall of the pocket and maintaining the space for clot stabilization. This method is derived from classic studies of Niemann, Linde, Caring, and Gottlob. The main principle behind this is based on assumption that only periodontal ligament cells have potential to regenerate of attachment apparatus of the tooth. Means periodontal ligament cells have potential or potential to get differentiated into various cells. So this GTR membrane are of two different types. Guided tissue regeneration membranes are of two different types, that is first generation and second generation. First generation membranes are non-resorbable membrane, means once you reflect the whole flap, after reflection of flap, this non-resorbable membrane can be placed in the area of after cleaning, after removal of granulation tissue, everything, guided tissue regeneration membrane can be placed. So vortex membrane are very commonly seen, that is non-expanded polytetrafluoroethylene membrane. Millipore filter or nucleopore filter membranes are there. They are reinforced with titanium mesh. Titanium is a metal. So because of that, these membranes are stiff, and only the disadvantage with this membrane is we need to do another second surgical procedure to remove this membrane. So second surgical procedure is also required to remove this membrane. Then second generation membrane are bioresorbable membrane. They are naturally obtained or synthetically prepared. So naturally obtained from animals like porcine. Other than that, we can use placenta, also human placenta as a membrane. Other than that, the available membrane like Biomend, Bioguide, Heliguide, Periogen, Paroguide. These are the different types of naturally obtained membrane. Synthetically prepared are polylactide or polyglycolide, Atrisorb, Epiguide, Guider, Biofix, Vicryl. So these are the synthetically prepared. But the disadvantage with this second generation or second generation membrane are they are not stiff because no metal is incorporated in this. So they are not stiff. So they get collapsed, and clot stabilization or wound protection get hampered because of that collapseness of membrane. So that is the disadvantage with the second generation membrane. Third generation membrane can be in that combination of resorbable membrane along with some growth factors are impregnated on that membrane. These type of membranes are not currently available, but they are in process. Then what are ideal requirements of guided tissue regeneration? Guided tissue regeneration, this membrane, GTR membrane should be biocompatible. Biocompatible means what? There should not be no immune response to that membrane. It should be there during healing, or it should not interfere with healing. Then stabilization of blood clot. It should stabilize the blood clot as it acts as a reservoir of precursor cells required for regeneration. Then cell occlusiveness. It should act as a barrier for certain cells that prevent the regeneration. Space maintenance. It should provide space for ingrowth of cell, potential for regeneration of adjacent periodontal ligament. Then it helps. It should help in tissue regeneration. It should be easy to use. Trim means what? We need to cut in proper shape to adapt on that wound area. Okay, it should be proper. It should be helpful. While it should be user friendly also. Indications: either grade 2 furcation involvement or narrow 3 wall defect or alveolar ridge augmentation. All these are indications. Contraindications of GTR are horizontal defect, tooth mobility, if soft tissue is not adequate, systemic diseases, if patient is having smoking habit, if defect is lesser than 5 mm, or wider type of defect is there. Then non-resorbable membrane, advantages of non-resorbable membrane, excision of epithelial or gingival connectivity, means it prevents epithelial cells to downgrowth. Then space maintenance, because it is stiff, membrane is stiff, longer persistence in site, it remains for longer time period. Absence of membrane degradation process, because it is not resorbable also, and it helps to stabilize the clot. Disadvantages are membrane exposure to oral environment may lead to contamination, infection, and there is second surgical procedure is required to remove. Then this expanded polytetrafluoroethylene membranes are popular as a GTR membrane for ridge preservation. They can be obtained in various sites. See, these are different sites. Shapes are also horseshoe shape or C shape or H shape. These are the different sites based on type of defect. Suppose a defect is there, only grade 2 furcation involvement is there. So you can adapt in that area of wound. And if on the both side defect is there, suppose buccal and leg both side are involved, then these kind of membranes can be used. Advantages of bioresorbable membrane are it reduces operatory time, more tissue compatibility is there, increased patient acceptance, elimination of second surgery, automatically it get resolved, so no second surgical procedure is required, and lower risk of post-operative complications. But this membrane can also get exposed to in the oral cavity, and it may lead to infection also. It may also act as a foci of infection. Disadvantages of this are high cost, then biodegradation rate can't be controlled because it get resolved faster sometimes. Lack of stiffness because there is no titanium incorporated in it, so it may get collapse, and wound protection will not be much proper. Then technique is what this is the surgical procedure in which a full thickness flap should be reflected always. Whenever you are going for any kind of surgical procedure, regenerative, see, full thickness mucoperiosteal graft is reflected. This is bone here. This is a defect. You can see a well-contained defect, 3-wall defect is there. So 3-wall, slightly buccal wall is not there, but partially it is a combined type of defect where vertically this wall is also present, this wall is present, and partial this buccal wall is also present. So because of that, after removal of granulation tissue, all granulation tissue is removed properly. This is a radiographic picture of the same defect. You can see. And every what granulation tissue should be properly removed, and then here bone graft. This is a picture of combined technique, but I am telling you, if you are not using bone graft also, complete removal of this granulation tissue, and then this kind of membrane is adapted in that area. Membrane should be sutured properly along the tooth, encircling the tooth, and then it should be again covered with the flap. Flap is reflected in this region. That flap is again placed in the area and sutured it. That. So this is the basic procedure. Any surgical procedure, full thickness mucoperiosteal flap should be reflected with vertical incision extending minimum 2 teeth anteriorly. Then debridement of osseous defect and curettage of inner surface of the flap. Root planing followed by root conditioning. Root conditioning, again we are going to discuss what is meant by root conditioning. It is a separate procedure. Then create a fresh bleeding at the defect site and allow the progenitor cells to progress from bone to the site. Then a membrane should be trimmed in that area and then placed properly, and it should be adopted. It should extend slightly apical, 2 mm apical to the defect, and laterally also. Means it should cover complete defect properly. Then membrane should be adapted to the site and stabilized with the help of suture or tacks. Then suture the site with silk suture or resorb any kind of resorbable suture. Then flap should be placed in the area and sutured again. Post-operative antibiotics instructions properly given. Smoking should be prohibited, and if non-resorbable membrane is used, then it should be removed after 4 to 6 months. So this is the again combined procedure which I have shown you. Now root biomodification. Root biomodification is a procedure in which a smear layer, once you remove the plaque, calculus, flap is reflected, then granulation tissue, everything is removed from the defect. the root surface which is there, it is a treatment for root surface. Biomodification means what? Using some biomaterial to remove the smear layer from the root surface. Because if root surface is not proper, or some granulation, some microorganisms are remain inside the root surface, then it will interfere with the attachment of the flap with the position. So because of that, various treatment materials are used like citric acid, EDTA, tetracycline, fibronectin. So this exactly this citric acid and all, it removes the smear layer from the root surface, and it opens the dentinal tubule. Patency of dentinal tubule is clear, and because of that, what happens? Citric acid pH of 1, and that citric acid should be applied for 2 to 5 minutes. It removes smear layer of microcrystalline debris and eliminates endotoxins and bacteria which are there inside the root surface. It exposes the dentinal tubule, appears wider with funnel-shaped orifices. Orifices of tubules should be opened wide so that the fibrin leakage, means early fibrin leakage occurs to the exposed collagen fibers, which prevents the migration of epithelial cells. That attachment, if takes place, then epithelial cells will be prevented on the treated root surface. Means epithelial cell migration will be prevented. It accelerates healing and promotes formation of new attachment by enduring cementogenesis and attachment of collagen fibers. Then second technique, root biomodification is EDTA, ethylene diamine tetraacetate. It is also used as treating the root biomodification. So this concentration of 20% at pH 7, it exposes again collagen fiber of dentin matrix. It improves clot stabilization, retards epithelial growth, down growth in the wound area is prevented. Then ETA has advantage over citric acid as it acts as a neutral pH. Fibronectin, again it is a protein, glycoprotein. It acts as an adhesive for attachment of fibroblast on the root surface. It is connecting protein, mononectin now. Okay, so the addition of fibronectin to root surface promotes connective tissue attachment and bone regeneration. Then another method which we use routinely in our clinic also, that is tetracycline powder for root biomodification. It removes smear layer, exposes inguinal tubules. In vitro treatment of dentin surfaces with tetracycline increases binding of fibronectin that stimulates fibroblast attachment and growth, which suppresses the epithelial cell attachment and prevent migration. It gives better results when used alone than in combination with fibronectin. This is root biomodification. Various studies, they have shown that even root biomodification is only procedure can be done. It will definitely help in the regenerative procedure. But it is not used as a single therapy for regenerative purpose. The lost structures are also should be. Am I audible? All of you are there?
Yes,
Yes, ma'am.
Okay.
Yes, ma'am.
So the third technique for regenerative, that is non-bone graft associated technique, is growth factors. Which techniques we have seen till now? Any one of you? See, again I
Yes.
repeat for you people that regenerative surgical procedures are of two types. First is non-bone graft associated technique. Second is bone graft associated technique. Bone graft associated technique, we will discuss it separately as a chapter. For today, we are going to discuss about non-bone graft associated technique. In non-bone graft associated technique, first is what? Guided tissue regeneration, where different membranes are used. In that, two different types of membranes we have seen. That is first generation or non-resorbable membrane that is expanded polytetrafluoroethylene membrane, which are incorporated, titanium mesh is incorporated. Second type of generation of guarded tissue membrane is resorbable membranes. In resorbable membrane, again naturally obtained and synthetically prepared. Naturally obtained are of from animals. They are obtained from animals like porcine, fish, or pork. They are obtained. The collagen membranes of their intestine are used. So they are resorbable type of membranes. Then synthetically prepared membranes are also available like atrisol, which is a polylactide polyglycolide membrane, combination of membrane. So these are the first techniques of non-bone graft associated technique. Which are the which techniques